But right now, I'm honored to introduce our distinguished speaker, Dr. Jamie Slaughter-Acey. Dr. Slaughter-Acey is an assistant professor in the Division of Epidemiology and Community Health, and she's faculty in the Center for Leadership Education and Maternal Child Health at the University of Minnesota. Her research primarily focuses on environmental and psychosocial factors that contribute to women's health across the life course. And she has an emphasis on maternal and child health for marginalized and underserved populations. Last year, she received the prestigious Matilda White Riley Early Stage Investigator Award from the NIH for her paper on skin tone, racial microaggressions, and delayed prenatal care. Please join me in welcoming Dr. Slaughter-Acey.
I am really excited about presenting my work with you all, and even more so for our discussion afterwards in the panel discussion, because I think we'll have a really rich conversation there. So as Pamela Joe said, I'm going to be talking about the cost of color, the cost of ignoring color in our fight against racial inequalities with respect to women's health. And for me, this quote by Alice Walker, I think, is core to the work that I'm doing. It's an excerpt that says, "To me, the Black woman is our essential mother. The Blacker she is, the more us she is. And to see the hatred that is turned on her is enough to make me despair almost entirely of our future as a people." Now, this quote, the excerpt that this quote comes from, Alice Walker is primarily speaking about in-group colorism, which I'll talk a little bit more about later, in which, as a form of internalized racism within the Black community. But the way that I'm going to speak about this about colorism, and the way I see this quote, is that it is central to the health of America, right? So not just racism within a group, but racism within a society that particularly affects the Black woman, the Black woman. So for over a century, and actually before this country was even formed, we've seen perinatal racial disparities that disproportionately burden Black women. And we see that in their access and quality of their prenatal care, whether or not they have complications in pregnancy, as well as their pregnancy outcomes, preterm birth, low birth weight, infant mortality, and in terms of, also in terms of pregnancy-related mortality in the US, where we see Black women are 3 times more likely to have pregnancy-related mortality than white women. And these trends have not changed since the formation of this country. And we can take those racial disparities in perinatal health, and we can look at other indicators of health for women, and we see similar trends, right? In which Black women are more likely to have hypertension. They're more likely to have a body mass index that's greater than 30, that puts them in the range of obesity. In terms of looking at life expectancy across the life course, I just sort of pulled out 2 time points. And we can also, we see that non-Hispanic Black women have the shortest life expectancy at birth, and that this gap in life expectancy persists across across the lifespan. And here at age 35, which is an important age that we use in statistics, in surveillance and monitoring, because it's sort of placed right in that middle of like prime reproductive health. And we see that that gap still exists. And so I believe this was 2018, 2019, New York Times reporter Linda Villarosa asked this really important question. And that question was, why are America's Black mothers and babies in a life or death crisis? And her answer was that it has everything to do with the lived experiences of being a Black woman in America. And you can take this question and you can take this answer and you can literally apply it to all the health indicators that I just showed you, plus many more that demonstrate racial disparities or racial inequities that exist for Black women's health. What I'm going to talk to you about is, or I should say that this is where my research, my program of research is centered. And so my discussion today is going to be focused more on maternal health, which is an important aspect of women's health, but I do want to acknowledge that women's health is more than just maternal health. But many of the things that I'm going to talk to you about are very relevant for not just for maternal health, but women's health as a whole. And so my program of research really just sits at that intersection between racism, both structural and cultural, colorism, and sexism, and thinking about the ways in which those intersecting systems of oppression impact maternal health through social exclusion, as well as through a biopsychosocial stress process. So there's lots of research, at least that's been published in the last 2 decades, that have just demonstrated this link between structural and interpersonal racism and adverse pregnancy outcomes for Black women. One of my sort of caveats about this literature, this important body of literature, is that in looking at Black-white racial or Black-white health disparities, it pretty much treats Black Americans as a monolith. And it sort of assumes that Black Americans' lived experiences in the United States are uniform, but they're really not. Racial classification, the way we use it here in the United States, very much intersects with other aspects that may represent social identity or social group membership. And that could include place, thinking about neighborhood and community, age and stage of life, historical context, socio-political context. And where I focus is on that ethnic appearance and of course gender, in being that maternal health, since the maternal health is a very unique part of health that is experienced by individuals with female anatomy. So skin tone. So the part of the ethnic appearance that I'm focusing on today is skin tone. And one thing to note about skin tone is that it's a little different than race, which race is a completely man-made social construct that represents this structural racism or racialization in the United States. Skin and has no biological meaning. Skin tone, on the other hand, or I should say skin color, there is a biological function to skin color, but there is very much a social context to skin color when it's situated within a context of racism. So on the left is a map of human skin color, and that's been assessed in indigenous populations around the globe. And you can see that geographic regions closer to the equator is correlated with darker skin tones. And that is because the melanin in our skin, melanin production is associated, or its function is to, it functions with UV light intensity. So our melanin, the amount of melanin that we produce in our bodies in, if we're living in an area that's closer to the equator, is higher, and that's in order to protect degradation of our DNA, our folate, from the UV light. And then at the more northern and southern regions of the globe, there's less melanin production, and that is to allow for greater vitamin D synthesis during the summer when there's the greatest amount of light at the poles. But and skin tone would still just be this biological construct if we had not, as a society, right, introduced slavery as we know it, and racism into the world. So I should go back and say, so if you see like the slave trade in terms of North America, South America, what I want to say is that skin tone as a social construct is not only in existence in the United States, but in other areas in which the slave trade was active. So it was, and it has been exported from the Americas back to regions in Africa. So this is the framework that I really like to work with or work from when studying racism health, because I think David Williams does a really great job of situating where race lies and where experiences of discrimination are situated in the causal pathway, and placing racism at where it rightfully belongs as a basic cause or fundamental cause of health. And that race and experiences of discrimination are manifestations of the system of racism. I have adapted this slightly to include colorism. So colorism is skin tone bias, and it is the child of racism, but it has really grown into its own system of oppression. So you could kind of say it is racism's offspring, but it's a rebellious adolescent that complicates things. The other reason why I really like using this framework is because I think Dr. Williams calls attention to the proximal pathways beyond experiences of discrimination. So in more detail in his work, he speaks about different forms of cultural transmission, but also in thinking about the responses, he also brings into the conversation those collective and individual resilience resources or responses that can impact health down the road. So skin tone in the context of racism. It really takes on, like I said, it takes on this social meaning, and it takes on this hierarchical meaning that assigns privilege and opportunity based on the hue of one's skin tone. And this privilege is often allocated to individuals with lighter skin tone and more European-like features. And as I said with the maps earlier, it's more pervasive in societies that have histories imbued with slavery and colonization. So skin tone may have more significance in the lives of women of color than men of color. And that's in part because of our definitions of beauty that have been equated with having light skin and having more Eurocentric features. And we can even think back to some of the stories, fairy tale stories, or other cultural references that we've been exposed to in childhood. And we can see how notions of beauty have been attached to lighter and lighter skin, right? So if we think about Snow White, her skin was fair, right? And if we think about what's defined as handsome for men, we use phrases like dark and handsome, right? So even the media, the beauty industry and media within the beauty industry has questioned its role in perpetuating colorism. And here's just a quote that says that beauty in the media gravitates towards white women more than women of color. And you're not supposed to be seeing anything, so don't panic. But one may ask, how prevalent is colorism? And I would say that it is actually quite prevalent. If you just go on to Twitter and you type in a hashtag for colorism or light skin or dark skin, you can actually see the prevalence of colorism in colorism operating in our society. So this was a tweet I identified, and a Twitter user posted or tweeted, "Black men claim they like natural hair, but which picture do you think they would choose?" So we have this beautiful Black woman and we have this beautiful Black woman. And another Twitter user wrote, "Most would choose the one on the right because she's more attractive than the woman on the left. Anything else?" And so that is just a really blatant, nasty, insidious example of colorism. And even if you look at the Twitter user's handle or username, right, the fact that it is light skin love is a consequence of colorism. And this is actually quite disturbing to me as a Black woman, and I hope it's disturbing to you all. But this is not a lone example. So in thinking about colorism and gender, the scholarship or the evidence that's available has shown that skin tone as a proxy for colorism has been linked with measures of self-perception, marital patterns. And when I'm talking about marital patterns, I'm not just talking about if you get married, but I'm talking about the age at when you get married. Lighter complexioned Black women tend to marry earlier in life than darker complexioned Black women. It influences your opportunities for mate selection, educational attainment, overall standard of living, economic, wealth and economic measures, as well as residential segregation. And where I have the little blue stars, that is where they found gender differences, or the literature's reported gender differences that disproportionately impact women. If we're thinking about the intersection of colorism and gender with respect to health outcomes, we see that color or skin tone has been associated with hypertension, measures of mental health and well-being, body mass index, and cardiometabolic health. And women have been disproportionately impacted in with respect to blood pressure, body mass index, and cardiometabolic health. And in looking at this literature, one of the things that really popped for me as a social epidemiologist, but as a perinatal or maternal and child health epidemiologist, is that all of these are pathways that racism may affect maternal health. But no one has asked that question until recently. Is there heterogeneity in Black women's birth outcomes in relationship to skin tone, in thinking about skin tone being a proxy for colorism? And so I had access to this really unique study called The Life Influences of Fetal Environments, in which it included 1,400 Black women who gave birth to a single live-born infant in metropolitan Detroit. And what was really unique about this data set is that we didn't just ask women about their exposure to major experiences of discrimination, like have you been denied credit, or feel that you've been discriminated based on in terms of getting a job or in public. We also asked women about exposure to racism in the form of racial microaggressions. We included a measure of skin tone and several other measures that may be important or are important to Black identity in this country. And so what I found was that racism in the form of racial microaggressions was associated with delayed use of prenatal care for Black women, and that this relationship was very much moderated by skin tone. And I want to say it's important that I'm starting out with prenatal care because there's nothing biological about prenatal care, right? So if I find that there is heterogeneity in experiences of racism, as well as a woman's access to prenatal care, there is nothing biological that is driving that relationship. So that was why it was really important for me to start off with prenatal care. And so here's a graph that just sort of demonstrates that variability in which here we see that Black women overall who experience greater racial microaggressions were more likely to not have prenatal care or have no or late prenatal care. But when we look at it over here by skin tone, we see that women on the ends of the skin tone continuum are the most likely to have women on the ends of the continuum who experience racial microaggressions are the least likely to have timely prenatal care. And I'll talk more about that why in a little bit. Okay, so then in a follow-up piece, I wanted to go the next step and look at Black women's birth outcomes. So in a follow-up study, I looked at, among these 1,400 Black women, I looked at skin tone in relationship to women's rates of preterm delivery, having a low birth weight infant, and how this relationship may be moderated by maternal age. And what we found was that Black women with medium to dark brown skin tones, they were more likely to experience a preterm birth with increasing maternal age compared to women with light brown skin, light brown complexions. And so some of this nuance that you're seeing in terms of the direction in which skin tone influences the relationship very much has to do with the complexity of colorism, in that it can function in group, it can function out of group, meaning, so in group meaning as a Black woman, that it is functioning, it's being perpetuated or experience it by other people who I identify as being Black or African American. Out-group colorism is that colorism that one experiences. So again, as a Black woman, that I may experience that is perpetuated by individuals who I identify outside of my racial group. And then gendered colorism, knowing that there may be some situations in which, as a Black woman, and not just that, some situations that may be specific to Black women that are not as relevant to men. Oh, sorry, let me scoot back to where I was. Okay. And so I think with access to care, the relationship that we saw with access to care, our dark complexioned Black women are experiencing colorism within and in group and out group with respect to their access to care. But I think that our lighter complexioned Black women who live in Detroit, which is predominantly Black, they may be experiencing consequences of colorism, meaning that they're experiencing consequences for the or prejudice based on the perceived privilege that is attached to their skin tone. And there is work that shows that experiences of discrimination within one system or in everyday life may lead to a buildup of vigilance, so hypervigilance, in which one taps into to avoid future experiences of discrimination. And so for our light complexioned Black women and our dark complexioned Black women, they both report greater experiences of racial microaggressions. And so they may be not engaging with prenatal care in part because of avoidance as a coping mechanism. So today I'm going to talk a little bit more about or pre-pregnancy health outcomes with respect to pre-pregnancy weight. Just really quickly, maternal weight is an important determinant of pregnancy health for both mothers and infants. Excess weight before and during pregnancies is associated with increased risk of pregnancy complications, higher risk of delivery complications, as well as adverse birth outcomes. And so when we look at this pre-pregnancy body mass index by race and Hispanic origin, we see the disparities that a similar trend that I showed you earlier, in which Black women are disproportionately in a category of BMI greater than 25. And, research looking at racial disparities and excess weight have, I think, done a pretty good job in looking at inequalities in the social determinants of health and how those social determinants of health link to excess weight. But again, most of this research fails to consider that racial classification is multidimensional. And so again, that's where this framework that I'm borrowing from David Williams comes in handy in thinking about how the racial disparity or the high rates of excess weight, pre-pregnancy excess weight may be linked with heterogeneity in experiences of racism. And so this is the conceptual model for my R21 that really builds on the work I'm about to show you, in which we have this intersection of SES, skin color, and race that may have a direct effect. Well, these as proxies of racism, skin color, and socioeconomic standing have a direct relationship on women's cardiometabolic health and their subsequent birth outcomes. And they may also have an indirect effect on women's psychosocial environment. So in the life study, this was the distribution of Black women according to their skin tone that they reported. And like other studies that have focused on colorism, the majority of women fall within the medium skin tone. And this is a slide that shows pre-pregnancy body mass index category for Black women in life by self-reported skin tone. And what we see here is, like I said, over 65% or around 65% of women have body mass index above 25, but we really start to see heterogeneity in excess weight by skin tone, in which our women who reported having dark brown skin tone are more likely to enter pregnancy at a BMI greater than 25, and our women who reported very light brown skin tone are less likely to enter pregnancy at a BMI greater than 25. So in thinking about colorism's connection or intersection with gender and beauty, the LIFE study is very unique in that it has 3 questions that ask about experiences of colorism. And here I present one of them because it is an example of gendered colorism. And it asked women, how often does the opposite sex find you attractive due to your skin tone? And we see that, and women could respond to this, never, not too often, fairly, very often. And women who reported that their skin tone was very light brown were most likely to report that the opposite sex finds them attractive due to their skin tone, whereas dark brown and medium brown Black women, complexioned Black women, reported that reported the opposite sex finds them, were least likely to find them attractive due to their skin tone. So when we look at pre-pregnancy BMI category for the Black women in life by our gendered skin tone bias category, we see that 42% or almost 43% of women who reported very often that the opposite sex finds them attractive due to their skin tone very often this is actually, they are in a healthy BMI range of under 25. So the legend has a little bit of a typo in it, sorry. And we see that women who report never or not too often, they are more likely to be in a BMI category of greater than 30. So then if we, let's see. Oh, this is, oh, I already went through that one already. Okay, so why is this slide doing this to me? Okay, so then if we look at the associations between skin tone and skin tone bias and skin tone adjusted for maternal age, parity, place of birth, education, financial situation, physical health, you very much still see that skin tone is associated with this experiences of skin tone bias. So here in is a regression model looking at the association between skin tone bias and and weight status. And we see that for women who reported never or not too often and fairly often relative to very often, they're more likely to have a BMI of greater than or equal to 30. For BMI between 25 and under 30 kilograms, we also see that association, but or that trend, but that association goes away once we've controlled for maternal age parity and socioeconomic indicators. When we look at self-reported skin tone, we see that, again, skin tone is associated with excess weight or having a BMI greater than 30. So women who reported very light or medium brown skin tones as compared to women who reported very dark brown skin tone were less likely to enter pregnancy at a BMI greater than 30. And then in the overweight category, or sorry, BMI between 25 and 29.9, we also see a slight difference between, or a gradated trend, but it's only significant between our medium brown and our dark brown complexioned Black women. And so what is this? I mean, the question is like, what is this? I mean, I think this is really important to kind of think about how one's lived experiences are not the same throughout life, and that and not the same within Black Americans. If we are to understand how does racism get under the skin to impact health, we have to really think about not just social exclusion, but also the way that we are experience social exclusion, but also the stress processes that link racism to our health outcomes. So one thing that's really important here that I kind of, you all may have questions on, is that the relationship between skin tone and our outcomes is not always exhibited in the same way, right? So if we think back to the prenatal care example, I said that my Black women at the ends of the color continuum were most impacted in having delayed prenatal care if they reported a greater amount of racial microaggressions. And we also saw a little bit of difference in the direction of the trend, or the direction of the association with respect to body mass index. And that very well may be about the relationship a reflection of the relationship or the research that's looked into skin tone and discrimination, in which there is a lot of mixed results. And these mixed results reflect differences in global measures of perceived discrimination, different domains that are investigated. So like I said before, there's major experiences, there's microaggressions. It could be influenced by the period of exposure, so ever or past year. It could very much be dependent upon where an individual lives, learns, prays, plays, works, right? And because of the scholarship that I just showed you, based off of the LIFE study, I wound up having the opportunity to insert a few of the questions into a prospective pregnancy cohort that was currently recruiting. And so I was able to insert maternal skin tone and a question about the racial composition of where people live, learn, play, work. And so what I'm really getting at is, you know, are racial discrimination and colorism functions of context? And does racial composition of where Black women live, learn, pray, work, moderate the relationship between maternal skin tone and experiences of discrimination? So this is the BIBB study that I talked about, which is the ongoing prospective cohort of Black or African-American women, 18 to 45 years old, that primarily recruited in metropolitan Detroit, but also in Columbus, Ohio. The data I'm going to show you is just a subsample of the study. And I'm in the process of rerunning the data so that on the full sample, which includes about 600 women. But as you can see, here is the distribution of women in BIBB by skin tone. There's really no differences in age, gestational age, parity. We have some minimal differences in education level by skin tone. To look at experiences of discrimination, we measured 9 situations in which women could report if they ever experienced discrimination attributed to race, ethnicity, or skin color. And so that could be in their interaction with police, schooling, work, obtaining housing, credit, in public, healthcare, other types of services. And we used the same exact maternal skin tone measure that we used in LIFE. And the distribution was very similar to that in LIFE. In terms of racial segregation, this was the question that we asked women. When you think about the places where you have lived, gone to school, worshiped, or worked, were they mostly Black or mostly white? And the domains that we asked were about high school, childhood neighborhood, present neighborhood, a church or a place of worship, and workplace. Women could report do not apply for church and workplace because those are not always relevant for everyone. And so those 5 domains really represented 2 factors. one in which the place, in the racial composition in which women learn, lived, and worshiped, and the other one is about where they work. And so just really quickly, because I know that we're running a little bit low on time here, this is the variability of racial composition by skin tone. And we see that lighter complexioned Black women are more likely to live, learn, and pray in more racially isolating settings, so more predominantly white settings, whereas darker complexioned Black women are more likely to live, learn, and pray in more racially homogeneous settings. There's less variability in terms of the work, our work factor, but there is some heterogeneity in which lighter complexioned Black women are more likely to work in racially isolated settings. Here's our experiences of discrimination stratified by skin tone. And again, this is the number of situations experienced, and we find that darker complexioned Black women are more likely to state that they've experienced a situation, at least one situation of racial discrimination relative to medium and light complexioned Black women. And when we look at our, our regression model with the association between maternal skin tone and racial segregation and the number of situations, we see that in just looking at the direct association between maternal skin tone and the number of situations, we're not finding an association here. But when we look at racial segregation of where we live, learn, and pray, we see that women who work in live, learn, and pray in more racially isolating settings as compared to racially segregated settings, they report a greater number of situations of discrimination that they've experienced. And when we put it all together, I think that's really the major piece here, is that when you look at that interaction between maternal skin tone and racial segregation, our racial segregation measure with respect to where women live, learn, and pray, and the number of situations that they report, we see that both skin tone and racial segregation matter in terms of the number of situations that these expectant Black women experienced, in which Black women who have medium to dark complexioned skin tones, as they move to a more racially isolating setting, which is higher number here, they report a greater number of situations in which they experience discrimination. For our lighter complexioned Black women, as they are in more racially isolating settings, the number of situations in which they experience racial discrimination decreases. But when they're in more racially segregated settings, meaning that they are in settings that are more predominantly Black, they experience a higher number of situations. So that really speaks, to me, this really speaks to to the function of colorism, the complexity that exists. And so I present all of this for those of you who are interested in racial health disparities, particularly those that affect women, to open your minds, your questions, programmatic questions, policy questions, research questions, to not just think about how racial health disparities come to light based on between group or between race differences, but to think about what is how does society, or how do the social determinants of health impact people within a marginalized group differently, and how that can very much dictate and influence racial health disparities or the health of marginalized individuals. And so with that, I will turn it over to Pamela Jo for questions.
Thank you so much, Jamie. I think what we'll do is we'll hold all questions to the end and we'll jump into the panel now. Like I said, Jamie's going to stay with us for the next hour. And so I am excited to introduce our three additional panelists. We'll start with Ryan Eagle, who is an enrolled member of the 3 affiliated tribes of the Fort Berthold Indian Reservation in North Dakota, the Mandan, Hidatsa, and Arikara Nation. Ryan is the Public Health Research Project Manager at the American Indian Public Health Resource Center, where he provides technical assistance to tribal nations on research processes, benefits, and barriers, as well as assisting with program evaluation, design, and implementation. Krissie Guerard is currently the Health Equity Director at the North Dakota Department of Health. She's been with the North Dakota Department of Health since 2006, where she started in the HIV, STD, TB, and hepatitis program. She later joined the Healthy and Safe Communities section as a maternal and child health grant coordinator. And Olihe Okoro is assistant professor in the College of Pharmacy at the University of Minnesota, Duluth. Her research focuses on social and behavioral issues in healthcare services and medication utilization, healthcare disparities, and cultural competency in pharmacy education and healthcare delivery. So welcome and thank you all for being here. I would like to start with all panelists briefly introducing the focus of your work and some of the health disparities that you see in your work, and then tell us a little bit about what public health professionals need to know about this. And so I'm going to start with Ryan.
Good afternoon, everyone. Like Pamela Jo said, my name is Ryan Eagle, and I work at the American Indian Public Health Resource Center. I serve as the research project manager, and we focus on addressing American Indian public health disparities through technical assistance, policy development, education, research, and programming in partnership with tribal nations across the United States. Compared with other groups or ethnic groups, American Indians have a lower life expectancy, lower quality of life, and are disproportionately affected by many chronic conditions. American Indians continue to die at higher rates than any other Americans in many categories, including chronic liver disease, cirrhosis. They have the highest rates of type 2 diabetes in the world, heart disease, malignant cancer, unintentional injuries, assault and homicide, intentional self-harm and suicide, and chronic lower respiratory diseases. Recent COVID-19 data indicates that American Indians and Alaska Natives also have a higher death rate from COVID-19 than any other race or ethnicity. For my tribal nation, the Mandan, Hidatsa, and Arikara Nation, the life expectancy for men is 52, and for women it is 54. Now you compare that with North Dakota, where the life expectancy for men is 77 and 82 for women. What public health professionals need to keep in mind about this is that continued and intentional underfunding of tribal health services, and particularly the Indian Health Service, combined with the lack of providers in Indian country, only exacerbates these disparities through limited access to care. The Indian Health Service is severely underfunded and currently funded at about 50% of their need. They have insufficient number of providers, and they are struggling to replace aging hospitals and facilities.
Thank you, Ryan. Olihe?
Good afternoon, everyone. Thanks, Pamela. So my name is Olihe, and I do health disparities research mainly with communities, so more community engaged type of work, looking at health disparities. I have worked in HIV disparities, but broadly, because it's community engaged, whatever happens to be of either interest or importance to the community at that time, determines what work that I do. More recently, we've been working on COVID-19 because, of course, we can see the disparities with communities of color. And so I've been working with the African heritage community, which is both African American and African born immigrants and those of, from other places. So we kind of have just termed it persons of African heritage. So that's just the Black community in general here in the Duluth area. So previously I've focused on chronic conditions because persons of color also have worse outcomes with a lot of the chronic conditions: cardiovascular, diabetes and metabolic syndrome, mental health, and a host of other chronic conditions. So those are some of the things that I have worked with. And also in terms of disparities, not just in incidence or prevalence or outcomes, there are also disparities in healthcare. And being a pharmacist, from a provider perspective, that is of great interest to me, because we see that sometimes it's not the disparities in the health itself, but in healthcare, in access, in how people are treated, in how people engage in, just a host of things. And sometimes even with policies, a lot of times with policies and processes that we have in the healthcare system. So there is a lot of intersection with structural inequities. And so because I work out in the community, I'm able to kind of see that. And that is what I charge both public health professionals and healthcare providers. Can we connect the dots? What we see in the clinic, what you see with the patient in front of you, or as you do interventions, and do community education and promotion and all of that, can you connect the dots between the disparities that you see and the structural inequities? Because sometimes what we need is a policy change. It's not to improve it's not behavior change. It's not more food. There are structural inequities that, are foundational to this, and we have to look inwards. We have to see what our systems look like, the policies, who do they benefit, who do they disadvantage. So those are the things that I keep seeing in my work, how the educational gaps that we see with kids, how it will show up as health disparities down the line, because we're going to see it come up with people having less opportunities. We're going to see income and wealth gaps. We're going to see less access because of insurance and access to information and timely care and all of that. So we need to be able to connect these dots. That's one thing that I will really stress. And the second thing, which Dr. Jamie talked a lot about, is just the intersectionality of some of these things. It's not just one thing. There is the intersection of race with gender, with socioeconomic status, just with a variety of things. So we need to pay attention at some of these nuances, because sometimes, in the scientific world, we kind of have a reductionist approach. We want to be able to categorize things. We want to be able to check boxes. Has transport, doesn't have transport. Sometimes it's not that way. Two people can have transport, and transportation looks different for the two of them. So those are things we need to pay attention to, that it's not have or not have. Sometimes we want to be binary because we want to reduce things to variables. Sometimes it doesn't work that way. So those are the couple of things that I would highlight. Thank you.
Thank you. Krissie.
Sure. So as the health equity director for the Department of Health, my area isn't so much in the field of research, but I really serve in that role of assisting the department with identifying and eliminating health disparities through identifying those health inequities, looking at prevention measures and interventions that will work the best in different communities with a higher burden of disease. And most importantly, and this has kind of been alluded to, but within those interventions, we need to be looking at those underlying issues of why the disease burden is greater. So addressing those social determinants of health, your economics, your access and quality of education, access and quality of health and healthcare, your neighborhoods, and that social context, and really figuring out what those barriers are to achieving good health and what barriers are greater in those different communities. Health equity has really become the foundation of the strategic plan for the department. And so we're really looking at, addressing health disparities as a part of all of our activities. And I think the one thing I would like to highlight the most is that if we really want the health in our state to improve, it's not going to be achieved without looking at those health disparities and really exploring the underlying conditions and why they exist.
Thank you. Jamie, do you have any additional thoughts at this time that you want to share?
Well, I don't know if if people saw me shaking my head. I felt like I was shaking my head the whole entire time each one of our other panelists were introducing their work, because I think all of what they're saying is just right on in terms of, if we are going to improve the health of this nation, we have to improve the health of our marginalized and our historically socially excluded populations within this country. Some of the work that I'm doing now, I'm writing a paper on maternal mortality rates for Black and Indigenous women. And, and it goes back to that Alice Walker quote I spoke, that Black and Indigenous women are our essential mothers. And until we can support them in having a healthy life and life expectancy that they should have, then we will not solve the public health issues of this country.
Thank you. All right, Ryan, let's start with this astounding statistic, and this follows well on what Jamie was just saying related to maternal mortality. So compared to non-Hispanic white women, Indigenous women are 3 to 4 times more likely to die of childbirth-related causes, regardless of socioeconomic status. So what are other aspects of social identity or other factors that you think may play a role in this and other poor birth outcomes?
Many of our Indigenous communities are located in very rural areas, so access to care is a big issue, and transportation is a huge factor in this. Also, having the knowledge of and access to prenatal care is another big issue. On my reservation, for instance, there's no hospital in which births can occur. So women, in some cases, have to travel 150 miles one way to Bismarck to have their baby. So what do you do if you don't have a car, no public transportation, and of course, Uber, Lyft doesn't service the reservation. And when they do get there, they experience racism from their care providers and in the policies and practices of the medical facility. Lack of health care. Many families or many individuals rely solely on IHS, and this will also play a role in their poor outcomes. And Indigenous women are often not believed about their pain levels. And healthcare providers many times are under the assumption that the woman has substance abuse issues. Additionally, not allowing cultural birthing practices in the delivery room is also an issue.
Thank you. Olihe, you've done research on HIV risk and barriers to care for African-born immigrant women. Can you tell us a little bit about the experiences of these women and the types of barriers to care that they face?
Yeah, absolutely. Yeah. So first of all, I just want to say that, also drawing from what Dr. Jamie talked about even at the beginning of her presentation, of just that assumption that everyone has a similar experience, but that's not the case because people are in different places, and there's different histories, there's different contexts socially and otherwise. And so we have to pay attention to that. So I'm an African born immigrant woman myself. So I did not grow up in the US. And so I come from a different culture. And I will tell you, and I came to the US to live when I was already an adult. And so my experiences are so different from someone who is born here but looks like me. So for some of these women, some of the context is really very sociocultural because they are coming with a different set of values. And so having some understanding of what that means. And so some of the findings that we had from this, it was a needs assessment that we did. It was very qualitative. Just going back to things like what are the cultural beliefs, what are the normative values and expectations, that they have of themselves and just their community around them, being women. And so you have women not being as empowered based on just, the cultural dynamics. And even though they find themselves in a different space, they still come from somewhere, and that culture seems to still, supersede whatever their experience is currently. And so we had things like intimate partner violence, which, the women would go through but will not speak up about as readily as maybe others from other populations would. You have a stigma that seems to be gender biased. Like if it's a man that has HIV, people don't like, once it's the woman, it doesn't even matter whether she got it from her husband. The issue is you're a woman, and there is that attribution, like you must have been promiscuous or it's just your fault. And so some of those types of things. And then you have the taboo just around discussing sex and anything sexual, so that people are not, they don't ask questions. They probably will not engage with the healthcare provider in terms of asking pertinent questions that will, be good for sexual reproductive literacy, so that at least they understand, if nothing else, your body, and what, how that poses a risk in any way, and the behaviors you can and should or should not engage in, and protective measures and things like that. So what we have done with this is just going off of those values to say what will work in terms of intervention for these women. So first of all, just understanding that the values are different, and can we pull from those values to actually do sexual and reproductive health education, just to increase literacy around that, so that the women can take charge of their own sexual and reproductive health. And why we tended towards sexual and reproductive health, because that's what's important to the African woman, her fertility and being able to have children. And so once you posture it that way, once you come with HIV, it's like there's a stigma around it if you want to do HIV intervention. But within sexual and reproductive health, you're then able to talk about diseases that, are associated with sexual, behaviors and all of that. And so that was very welcoming for the women, to be able to talk about that and actually sit and exchange thoughts and ideas, more like in a support group kind of setting. So we've been able to pilot that, and it seemed to be well received. So what I would say with this is a culturally responsive approach is something that is needed, not just for this population, but for different groups of women. And I would also say that within even this broad group of women, you have different groups too, because how people migrate, will also speak to where they are at, because there's some intersection with socioeconomic status. There are a lot of women that come because of education, and so they are highly educated, and others are coming as refugees, and so it puts them in another docket. And so you have that intersection with socioeconomic status and whether there's a dependency that then puts them more at risk because they're dependent on someone for their, food, or maybe they can't speak English, and just a whole bunch of things like that. I'll yield.
Thank you. So Krissie, we've already talked that health disparities go beyond race and ethnicity. Can you talk to us a little bit about your work setting up advisory boards that are involving new Americans, immigrants, LGBTQ two-spirit, and youth groups?
Sure. In fact, it's probably one of the most exciting and rewarding experiences I've had in my career. So I'm happy to talk about the work that we've done at the department, because I really think that community input and community engagement is so important, especially because it can make or break relationships within communities. So having these advisory boards has been an awesome experience. In my career, I have really specifically been more involved in advisory boards specific to HIV, because I spent most of my career working with HIV, but I haven't been involved in advisory boards like this, where they're actually looking at health of certain communities as a whole. So it's really exciting. So in June of 2020, kind of right in the middle of the heart of the COVID pandemic, we were doing a lot of work within the new American immigrant and foreign-born population. And I'll refer to them as NFI, because that is what we call the advisory board, is the NFI advisory board. And we had always talked about having a board like this, but I think because of COVID, it just kind of made everything go a little bit quicker. And they have been awesome. So this board really provides us ongoing recommendations, how we can integrate NFI concerns into our policies and interventions. It provides a platform for leaders to elevate their concerns from their communities. They have a role in planning and decision making. And I'm just going to give kudos to Alicia Belai, who's in our health equity office. Because of her, this happened. And so she deserves all the credit. I'm just the one talking about it. But they've already created a COVID-19 task force. They've been helping us on education and translation and vaccine hesitancy. That board represents about 20 NFI community members around the state. So it's been really an awesome board. We also started the LGBTQ2S plus advisory board, which we call the BU advisory board. That's a very long title. Same thing with that board. They just started in the beginning of 2021. They have 20 members from across the state of North Dakota. They also have established a COVID-19 task force as well, that's really ensured that we've been addressing their community concerns around COVID as well. And they're really helping us, making sure that we are having that LGBTQ2S plus perspective in our planning and decision making. The newest advisory board that just had their first meeting in March is the Youth Advisory Board. That group is made up of 35 members. We had over 150 applications in North Dakota, which was so impressive to see how many youth in our state really wanted to make a difference in their communities around health. And same thing with that board. It's really there to provide recommendations on youth health issues and topics to the North Dakota Department of Health. I don't know about some of you, but I'm 41 and it's been a long time since I'd be considered a youth, and I don't really always have that perspective. So being able to have them in our corner is awesome, and I'm excited what that board is going to do. But I think just the most important thing with all of these boards is that this is bidirectional. It's just not the health department asking them about things we need their assistance for, but really them bringing their concerns to us. And on the other side of this, also making sure we're using their input and not just getting it. Being able to report back to them what we've done with the outcomes of their ideas. And we really want to make sure that they have a voice and feel like they're making a difference and really building up their communities. So it's been very exciting.
Thanks, Krissie. And so on the sort of the positive side of things and where we're trying to go, Jamie, one of your goals is to use your research to create community-based solutions. Can you share some examples of how your research is translating or can be or will be translated to community-based solutions to improve maternal child health outcomes, especially for Black and Indigenous women?
Yeah, I mean, I think, that's one of the things that I've had to grapple with ever since I've started this journey of being a public health practitioner who wants to address racial inequalities in maternal health. And part of that is because I have always gotten the question, what can you do about racism, right? And that really comes from a false or flawed understanding or conceptualization of racism, in which we believe that it's static, that it is non-modifiable. And we really need to understand that it is very modifiable. If we look at the 400 years of slavery in what is now the US, and we look at over 500 years of colonialism and what is now the US, you can see how these systems of oppression have morphed over time, which means that they are modifiable, right? They get changed in the way that policies are created and exerted and impact individuals within our society that we live. And so one of my goals is to, or one of the reasons why I generate this type of research, right? Or this type of understanding and filling the knowledge gap is so that we can develop more informed or better informed policies that are not colorblind, right? And that these policies are developed understanding that individuals at the margins may be disproportionately affected by colorblind policies, right? And I think we see that very much occurring with the COVID-19 pandemic, and it's laid that to bear. But within that pandemic, you have seen communities taking into account structural racism and how to create policies that do not disproportionately affect Black Americans in terms of their risk of exposure, testing, access to care, and vaccination. And so that's one of the places that I hope to see, or one of the reasons why I do the work that I do. Another reason why, or where I hope to see my work go, is creating, is the development of programs that can help buffer against structural racism, right? So while I'm fighting to tear down structural racism because it does have to go, I also recognize the fact that structural racism, it's very complex, and it may take a little while before we have this system torn down. And so in the meantime, I need to be creating interventions that push back against this system so that my Black women, right? Black Indigenous women can have the best opportunity for optimal health in this country, right? The other piece of it too is that in recognizing, in looking at the parallel histories of Black individuals in what's now the United States and Indigenous people in the United States, they have trajectories that walk very parallel with one another in terms of how structures have socially excluded them or marginalized them, right? And some of their histories are overlapping and intersecting, right? And in looking at these histories, one can see how, again, how these systems of oppression have changed with time and with political activism, if that makes sense. And while it does shift how these systems of oppression exert themselves, it doesn't mean that they completely go away. So part of my job as an epidemiologist is to monitor and do surveillance, right? And I see that as monitoring and doing surveillance in the ways that racism and colonialism and capitalism are exerted in society so that we are not caught off guard by a new face of racism or these other systems of oppression that emerges. Because that's what's happening now, right? We had the, and speaking specifically to African Americans, right? We had the civil rights movement. And in the way that we are taught about the civil rights movement and the end of Jim Crow, we have falsely taught people to think that racism ended with the end of Jim Crow, but it didn't. It morphed into a different face in which it acts more prevalently, right? And that has to be monitored, and you have to do surveillance on it so that you can act on it, so that you can name it, understand it, and act on it.
Thank you. Ryan, can you tell us a little bit about some of the most urgent needs, maternal child health needs in Indigenous populations right now, and maybe share a couple of the solutions or successes that are addressing some of these needs?
Sure. There are a lot of MCH needs in Indian country. I'll give you a few examples. Neonatal abstinence syndrome, that's an issue. Strategies for engaging mothers who are using for prenatal care, it's a big issue. As I alluded to previously, transportation, having to travel off the reservation to have babies, in excess of 150 miles one way. Fatherhood, the inclusion of fathers in conversations about maternal health and child health to address health disparities. There's a need for midwives and doula services in our tribal communities. We need to address perinatal mood disorder. There's a stigma in tribal communities around this that needs to be addressed, and it needs to be destigmatized. And there's also a huge need for respectful, culturally appropriate care. Cultural misunderstandings and implicit bias affect both the treatment and the desire of Indigenous people to interact with the medical establishment. And it can explain why Indigenous women in urban areas do not fare any better than those in rural communities. Some of the solutions that we've encountered in our work through the center, the MOMS program in White Earth is helping pregnant women, pregnant people that are addicted to opiates to get Suboxone and provide them with substance abuse treatment that incorporates their baby, their partner, and family in their treatment. The Turtle Mountain Band of Chippewa has a fatherhood program that is working to strengthen the relationships between a father and their child. With help from their program services, which include responsible parenting, economic stability, and healthy relationships. And institutions such as Sanford Health have begun to address the need for culturally appropriate care through the hiring of Indigenous people, such as Dr. Michael LeBeau, who is the president of Sanford Bismarck, who has in turn recently hired the former North Dakota Indian Affairs Commissioner to be the head of Native American outreach for Sanford Health.
That's great. Olihe, you're trained as a pharmacist and active in research and instruction in the School of Pharmacy. Can you just talk to us a little bit about how pharmacy and pharmacists can make unique contributions to addressing health disparities, and particularly in areas of women's health?
Sure. So I had talked a little bit before about just connecting those dots, what we see when we provide care in the pharmacy and the hospital to what's actually happening outside the healthcare system. And I think one of the ways, personally, as a, just speaking from a pharmacy educator perspective, is that we need to do better with training our students so that the workforce that goes out are actually able to connect those dots. And so we will do better. We're working on that. But in terms of just pharmacy practice, and patient care currently, what can we do towards health equity, especially for women? I know that pharmacists are, in terms of the patient care process, actually get to see more about the social determinants that probably a whole lot of other healthcare providers, because they get to interact and interface with things like insurance. They get to see when people come in and what the issues might be with access and with obtaining their medications and things like that. And so one of the things that I, really would like to see pharmacists get more and more into, being it that they actually are so uniquely positioned to be able to observe some of the things that have to do with, women and their health, is advocacy, and engaging in policy. Because pharmacists, we have a voice, and very trusted too within the healthcare system. And so being able to I'm not saying to take our eyes necessarily off patient care, but to broaden our scope so that it's not just about the one-on-one care to this one woman, to that one woman, which is very great because we have to do the one-on-one care. But can we broaden our scope a little bit to capture the more social and structural things that impact care for these women? And so that's an area where I think it will be good. Probably will also go back to even how we train, our healthcare providers, how we train the students to be able to see that. Another way that I feel that pharmacists can also help is just engaging with communities to just better understand some of the cultural nuances too. We are a lot in our own spaces, and I would say not just pharmacists, but healthcare providers in general. If you can go into the community just as a person and be in the community, attend their events, share in their, be in their communal spaces, and see what's important to them, see what they value, because they bring that with them when they come to receive care. Then you're better able to respond to their needs. So just that cultural responsiveness, but we can't do it, while we're siloed in the healthcare system. There has to be enough of that exchange. So posturing ourselves as learners too, because these women have the expertise themselves. Last thing I will mention is listening, because women of color, Black women, Indigenous women, the one key thing I hear in research all the time is that they don't feel heard. Just, can someone hear me? That's the echo all the time. Like, I don't feel like I'm being listened to. Like, I'm talking, but I feel invisible, and I feel like nobody is actually listening to me. So can we hear them? Can we hear what they're saying? Can we acknowledge this person in front of me? And hear them out and validate what their experience is. Ryan had mentioned even about with things like pain. And it's still ongoing. We talk a lot about historical distrust. There is contemporary experience. There is a lot of contemporary experience that continues to, feed into that historical distrust. Because after you have had something and then you experience it, what else is remaining? You're seeing it. So this women in particular, because that's where you have that intersection of race, ethnicity with gender. women of color don't feel heard. And I can say, even when you are empowered, I'm educated and I still go places, you know, and people want to look at you like you don't even, you're not, I see it, I experience it. It's experiential, very experiential. So can we see them? Can we hear them? And so it will also go back to maybe how we train and how we address some of these things. But I believe the needle can move. It will take time, like Dr. Jamie, you know, talked about. It will take time, but we need to continue to push. We need to continue to push. We need to continue to learn. We need to continue to, you know, have a paradigm shift, you know, one step at a time, but we should get there. Can we hear them? Can we see them? That's the plea.
Thank you. One last question for Krissie. Olihe talked about the importance of engaging with community. You talked previously about the advisory boards and you know, the bidirectional relationships. Can you just talk a little bit more about sort of what community engagement is and why this is so important to your work in addressing racial health disparities?
Yeah, and I love the listening part. That was awesome. I think that one of the most important things I've learned in my public health career is that you need community engagement. You have to have it. And what works in one community and within different races doesn't necessarily work in another. And I think that's that concept of listening right there. And truthfully, I didn't even really always know that. And I know that that seems like a naive thing to say, and that it's an easy concept now, is that you need to listen and that what works in one area doesn't work in another. But, you know, when we start in public health and you work with CDC and HRSA and things like that, and they have all these evidence-based interventions that they want you to do and or are required to do even sometimes. And what I found was, you know, they didn't work in North Dakota. And you really learn quickly that you can't have this one size fits all approach, I think, to public health. And I think most importantly is going back to that listening, is that you can't make assumptions that you know what communities need without getting that input. If you don't get that community input, like I said before, you can ruin those relationships and trust within communities. And in order to really, you know, achieve making that dent in those health disparities and those underlying conditions, you have to have those good relationships. And that's going to be essential to quote unquote move that needle. So I think listening is probably one of the most important things I've learned, is that I can't make the assumptions. I'm not in some of these communities. I can't make those assumptions for them. We need to hear from them.
Thank you. I am going to turn it over now to my colleague, Mark Strand, to kind of give us what you've got from the chat and audience questions.
Okay, yeah, thank you. So there's some questions that have come in the chat. This one would be for Dr. Jamie. In what ways is skin tone, BMI, and discrimination in the US similar to other countries? Is there any like global insights in some of these issues, given the America's unique colonial history?
That's a really good question. So what I would say is that while the US has its unique take on racism, it is not the only place in which racism exists, or anti-Blackness exists. And, you know, while with the slave trade, anti-Blackness was, you know, brought to these shores, we have exported anti-Blackness back to the places in which Africans were kidnapped from, right? And so while there are nuances here with respect to the way that racism and colorism looks, they're very much alive in other places. And I'm more familiar with work outside of the US in the other parts of the Americas. But you very much do see this relationship between skin tone and discrimination, perinatal health outcomes, for example, in Brazil, etc. What's important, I think, to recognize is that it exists everywhere. Anti-Blackness exists everywhere. And if we don't accept that fact, then we're helping to perpetuate the enduring nature of racism and colorism. And what I would say is that the situations in which discrimination is experienced based on skin tone, some of those situations will be similar to those in the US, and some of them will be different, right? Because context matters, context and culture matters.
All right. Another question is getting at policy and structural changes. So in particular, women seeking obstetrics care and then facing the disparities that have been described so eloquently today. If any of the panelists could speak to the possibility of expanding privileges to midwives, doulas, other wraparound services, community support, et cetera, to enhance that obstetrics care programming beyond just sort of like the clinical, like medical heavy care that's needed. Anybody able to provide any experience or response to that question? Maybe it's kind of a proposal, but if you have any thoughts or experience with that as a potential solution.
Well, I'll just say that I think there is, I think there's definitely a need to expand these services, right? And to expand the autonomy within these services, right? And I think some of the research supports, some of the really great research that's going on supports the use of doulas and midwives, especially when you're talking about Black, Indigenous, and communities of color. What we need to, in creating policies that increase the availability and access to doulas and midwives, there's a couple of things that we need to do to make sure that these policies don't turn doulas and midwives into one size fits all, right? And then sort of corrupt their benefit within marginalized communities. And that is ensuring that people from the communities most affected by inequities, these perinatal inequities, have the opportunity to train as doulas and midwives so that they can serve their communities, right? They know their communities best, right? We need to make sure that there are policies that provide reimbursement and payment to midwives and doulas that's no less than a living wage, right? So it's, yes, we want to try to expand these kind of services so that all women have access to them, but in trying to expand these services or support these services, invest in these services, right? We need to center groups who are at the margins so that we don't exclude them from these important services that can provide, you know, benefit and safety in which, you know, Black, Indigenous, and other women of color, you know, deliver their children in. So.
Krissie, I'm sorry to catch you while you're handling a sneeze, but I couldn't help it. You're the equity officer for the state. And this seems to be an issue that pertains to that. Is this something that is there any effort in North Dakota toward that end? In particular, that sort of wrap around multifaceted support to people who are particularly representing different cultural groups and the obstetrics care issue.
I totally apologize. I'm getting over a cold, so
yes. I didn't want to not give you a chance to answer. And I'm also thinking about Ryan. Your comment regarding the 150 miles away thing. So if either of you has any response from the North Dakota situation regarding this issue, I'd love to hear from both of you. In fact.
Yeah, so at least on the maternal mortality that Ryan alluded to earlier, they are in the legislative process of putting together that maternal mortality review committee. There has been one in North Dakota, but not a formalized review committee. So I think that is going to be really essential in moving that needle there and addressing some of those issues. And I will say not just on the mortality, but on the morbidity front of that too. So it's not just focusing on the mortality because as we know, it's not always, the death rates of the infant mortality, but more so just, those underlying conditions that could have been, may not have happened with the proper care beforehand. And I'll let Ryan chime in there too as well.
Yeah, I would just again highlight that some of the biggest obstacles for our Indigenous communities is that gap getting to their provider. Again, 150 miles one way. If you don't have transportation, that's a huge barrier, a huge burden for a family or an individual to try to overcome. So midwives, doulas, they're needed in our tribal communities. And yes, they need to be Indigenous. And home visits, that would be great. There's so many rural communities, not only tribal, that would really benefit from these services. So I think it's definitely needed. And especially the compensation part, so that the state and the feds recognize that and they're compensated adequately.
And it is something, just to add on to your transportation issues, Ryan, I mean, it's something that we've been talking about, in the department as a whole. And it's just been highlighted within the COVID, pandemic. All of the issues around transportation in North Dakota are huge. And how are we going to address that? And I think that some of these things we're addressing with COVID, whether it be the talks of more mobile services that can happen. And COVID is, with COVID money, is letting us plan and try to do some of these things, but it's that infrastructure building. So then we can potentially keep this going on instead of it just being a one and done thing. So I think there's some things in the works that are really going to help with those transportation issues, but we've heard it about everything, the testing, the vaccinations, and just that inability to make it to a clinic if you're sick. And so I think that those are things that we really need to look at going forward. And it's not only going to help just the COVID, it's going to help all of these other things down the line as well, because we'll be building that infrastructure.
I just want to thank all of our keynote speaker, Jamie, and all of our panelists for sharing your insights and your experiences and the work that you're doing. And I think, I know, speaking for myself, I've actually learned quite a bit today. And so I really appreciate you taking this time out of your days to come and share with us. So thank you.